Okay, and good afternoon, and welcome to the Davies Use Case webinar being presented by Mercy Health on improving quality and care gap closure through primary care rooming design. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicle for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information technology-enabled care delivery. So it's my pleasure to welcome our speaker for today, Carrie Pollack. And Carrie, I will turn this over to you. And you can begin when you're ready.
Great, thank you so much. Again, my name is Carrie Pollack. I'm a Senior Application Analyst on the CarePath Epic Systems team here at Mercy Health. And today I'm excited to share with you how we completely redesigned the way that our clinical staff who work in primary care interact with the electronic health record in order to improve quality and improve care gap closure for the health of our patients. First, I'd like to provide a brief overview of Mercy Health. Mercy Health is a Catholic healthcare ministry serving Ohio and Kentucky. On the map, you can see the areas in which we serve. And our mission is to improve the health of our communities, emphasizing people who are poor and underserved. Here's a little bit more about Mercy Health, the communities we serve through our employed offices and our affiliated partners, and some statistics about Mercy Health. As part of our mission, we've invested over $384 million in 2017 to benefit communities where we provide care. Throughout today's presentation, you'll hear me refer to CarePath. CarePath is Mercy Health's branding of the Epic Systems EHR, and the PATH in CarePath stands for Patient-Centered Access to Team-Based Healthcare. So again, throughout the presentation today, when I do refer to CarePath, that is our Epic Systems EHR. Here's a little bit of information about our governance structure here at Mercy Health. We rely heavily on our clinical informatics committees to provide input on major system enhancements and changes. We have ambulatory, inpatient, revenue cycle, and emergency department informatics committees that all meet to discuss upcoming changes, enhancements, and feedback on the system. We also have physicians who are practicing, who are certified in Epic, who also contribute to our build and enhancement process. Here's a list of some recent accolades. And without further ado, I'd like to jump into our outpatient case study. And again, excited to share with you how we completely redesigned the way that our clinical staff who rooms our patients in primary care offices use the electronic health record with the goal of improving quality, data capture, and closing care gaps for our patients. So the challenge before us is that primary care is responsible for a lot of tasks when it comes to taking care of our patients. And a lot of those tasks and responsibilities fall to our rooming staff, typically our medical assistants. And as that list is ever increasing, we noticed that certain tasks were being missed, be it annual screenings or certain important data capture items. And additionally, our care gap closure rate was low. So for this project, the opportunity before us and our list of goals, as you see here on the screen, was to streamline and standardize our rooming workflow for our primary care offices and across our entire system, including our affiliate offices, so that tasks needing completion during today's visit for a given patient were easily identifiable by the rooming staff, and that we would increase the capture of those important data items, and that we would also involve the rooming staff with the important task of increasing care gap closure. And we did not want to add to the time that it would take to room patients with this project. So another important goal of this project was to look for opportunities to increase efficiency within the system so that we could add potentially additional tasks to our rooming staff without increasing the end time that it takes to room a patient. Here's the timeline of our implementation in 2017, and I will get into a little bit more detail about our implementation approach later in the presentation. As you saw on the slide that showed the communities in which we serve, Mercy Health is a large organization. When I talk about this project impacting primary care practices, that is the loose umbrella that I will talk about to include practices that have a designated specialty of primary care, internal medicine, family medicine, pediatrics, and geriatric medicine. So we knew going into this project that we would be impacting over 300 unique practices and over 1,200 users. So it was important to us at the beginning to engage end users in this project to make it as efficient as possible in the end and minimize any disruption that this change may have on our end users. So we started off with a survey of our clinical staff, and we had great response with over 578 responses. And we wanted to get feedback from our end users on what tasks took the most time during their rooming workflow so that we could look for opportunities to improve efficiencies in those areas. And also wanted to know what areas of the chart they did chart review either before the patient arrived or while they were rooming the patient to see if there was any way that we could present that information to our rooming staff in a faster way during the visit. Through that survey, we also got volunteers to participate in a future series of work sessions where we provided demos of the new system build and got feedback throughout the design phase of the project. And because our goal of the project was to improve quality and care gap closure, we also included members of our various quality teams to look for additional opportunities on ways that we could improve data capture and quality items throughout this project. There are three primary ways in which Health IT was involved in this project. This slide provides an overview of those three areas, and then I'll get into a little bit more detail on upcoming slides. The first big project before the project was to consolidate our system build so that we were implementing a solution that was going to be consistent across all of our primary care offices, and we were doing so in a way that we were able to come back later and provide enhancements in an agile way. The second big task for Health IT was to completely redesign the user interface that the clinical staff who room our patients see inside CarePath. Again, with a focus on efficiency so that this new project would not add to the overall time that rooming staff spent rooming patients. And finally, the biggest piece for Health IT in this project was the development of new tools to improve our data gathering, our quality, and our care gap closure. So let's jump into each of these 3 items in a little bit more detail. So as I mentioned, a big part of the pre-work for this project was consolidating our build. So from an analyst perspective, prior to this project, anytime we wanted to do an enhancement for primary care, we had to touch over 300 individual unique configuration records. Every practice had its own unique configuration record. We knew that we wanted to create a standardized solution, so we wanted to narrow down those configuration records and have all of primary care share one configuration record. This would allow us to deploy a consistent solution while also giving us the agility to come in later and make additional enhancements and ensure that everyone working in primary care would see those enhancements or those workflow changes in a consistent way. Unfortunately, we weren't able to consolidate down to one configuration record due to our markets and the areas that we served, as shown on the map earlier. We do have some differences in our ancillary systems and some of the ordering codes that we need to use in the various markets for lab and imaging orders specifically. But we were able to pare those 300 records down to 11 configuration records, which allowed us to ensure that we were going to deploy a consistent solution to all of our markets and that future enhancements could be done much more quickly than they would have been prior to this project. The second big area that Health IT was involved in was the complete user interface redesign for our clinical staff. I have 2 screenshots here to show you the before and after to give you a general sense of how the screens changed. So on the left, you see there's a lot of empty space in the middle of the screen, and there are a lot of options presented down the left-hand side of the screen. With the new user interface, we were able to take advantage of what's called the sidebar on the right-hand side of the screen that allows us to show information on one tab and have documentation of notes on the second tab. We also tried to streamline the options that a user sees while also allowing them to jump out to common activities that they may need to access during the rooming of patients. And users can also customize their workspace, but we wanted to start everyone with a clean slate to streamline the look and feel of the new user interface. We'll talk about our training approach later in this presentation, but as we all know, as much information shared ahead of a go-live and as much training as you can provide, some folks are still caught off guard the day of a go-live. So with this project, for the first time ever, we utilized on-screen, just-in-time training information to remind end users that there is something different going on today, how to contact the support desk if any issues arise, and also a quick link to the training materials that were shared ahead of the go-live. In terms of user interface redesign, another enhancement that we pursued as part of this project was how we instruct clinical staff to queue up medication reorders for the provider to review. During our survey, that was the #1 piece of feedback, as the most time-consuming part of the rooming process was medication review and queuing up reorders for medications. Prior to this project, the staff had to leave the main screen that they worked from when rooming a patient and go to a different screen to reorder medications. As a part of the redesign, we took that feedback and we made the reordering of medications the next step directly in line on the screen within their workflow after reviewing medications with the patient. The third major and final bucket of the Health IT involvement in this project, as I mentioned, are the new tools that we developed to meet our goals of improving quality and patient care gap closure. One major piece of this is what we call the visit or the rooming checklist. This is the primary piece of information that appears in the sidebar when rooming staff is charting as they're rooming the patient. The visit checklist is essentially rules that are running behind the scenes that are evaluating that patient and that visit to determine what data items need to be captured, what screenings are due during that visit, and any other items that we want to bring to the staff's attention. As many screenings are due on an annual basis, prior to this project, staff would have to dig through the chart to determine when the last screening was done for depression, for example, and determine if it's due today. We've saved those clicks and that time by letting staff know right here when they open the chart if the depression screening is due today. This visit checklist is highly flexible, and we've added items to it and modified items since go live to meet the needs of our quality measures and our end users. Here's a list of our current primary care visit checklist items. As you can see, some of these items are related to data capture, some are related to whether or not screenings are due, and also we're advising staff, if the patient is not currently signed up for the patient portal, to go ahead and sign them up right there in the office with our My Chart Status Inactive rule. The way that we trained our staff to interact with this visit checklist isn't to work these items top down, but rather go through the rooming workflow as they've been trained to do and reference the visit checklist when they get to the point where they're ready to complete the screenings to see what is due, and then as one final check before they leave the room. If something has not been satisfied on the visit checklist and the staff doesn't recall exactly what's needed to satisfy that visit checklist item, we decided to include a detailed description of each of the visit checklist items and what is needed to satisfy that item from this hyperlink explanation of visit checklist items immediately below the checklist. We found that this would be much more helpful than staff having to reference a tip sheet or something outside of their workflow while rooming a patient. So I've highlighted one example that weight will show as needing to be documented every 12 months for adults and every visit if the patient is under 18 or if the visit is a Medicare annual wellness visit. This one example shows the extreme flexibility of these rules that not only based on patient age and gender, but even what type of visit this is to determine whether or not a particular data item needs to be captured during this visit. As we continue to modify the visit checklist, we also, in parallel, update the explanation of visit checklist items so that it is always up to date as a great reference point for our staff. While also working on the sidebar on the Review tab, next to the visit checklist is a report called Patient Info. This is a special report designed just for rooming staff that brings out pieces of information from the chart that they reported through the survey and the work group sessions, or pieces of information that they oftentimes found themselves looking through the chart to find. And this way they have it right at their fingertips on the screen while they're rooming the patient, saving clicks and time, not having to dig these items up within chart review. So just a few examples of what they said they wanted to see on this report, and again, this was specifically designed for our primary care rooming staff. Recent vitals, recent lab visits. If any orders have been placed and are hanging out there and haven't been completed, our staff would see those and be able to discuss those with patients. Completed health maintenance or preventative screening items. If some patients want to know when they had a screening item done in the past, that's when they might be due for it again. The completed health maintenance items are there as well. Within the recent outpatient visits, staff can easily get to a progress note of a previous visit by clicking on the hyperlink of when that visit occurred. Can view any upcoming future appointments for the patient and other information that they shared with us through our feedback sessions and survey. And again, this is highly flexible and can be updated over time to save time not digging through the chart during the rooming process. The other major tool that was a part of this project was an order set related to health maintenance or preventative screening orders for that patient. In order to help increase our care gap closure rate, we wanted to involve our rooming staff in pending any orders for items which the patient is overdue for or will be due soon for. Not only does this help close care gap orders for our patients, but gets these items in front of the provider with the appropriate screening diagnoses ahead of the provider coming in to see the patient. As part of the visit checklist report on the right-hand side of the screen, all of the health maintenance items are clearly identified there for this particular patient, and within the workflow on the left-hand side of the screen, the rooming staff can open this order set. This rooming staff health maintenance smart set was a large undertaking given all of our different markets and the different orders that each of our markets use specifically for lab and imaging. But we felt that designing this smart set specifically for our clinical staff was something that we hadn't done in the past. A lot of times order sets focus on provider use, but that we could save our providers time by queuing up these orders, as well as help prevent errors of omission by not queuing up these orders if it was left up to the provider alone. Anything that the patient is overdue for or due soon for will automatically be checkmarked within the health maintenance smart set. A couple of exceptions to that is if the office needs to decide if they're going to do a send-out lab or a point of care test, or if some items might differ based on insurance needs. The screening diagnoses are already associated with the orders, so those will be connected appropriately when the provider signs these orders and will help avoid any false firing of advanced beneficiary notices when the provider signs the orders. Currently, we have 14 care gap orders included in this health maintenance order set, and show and hide based on the appropriateness for that patient and the correct order based on what market this visit is taking place in. So it really is a super smart set. So with the build completed, our next steps for implementation included user acceptance testing, where we had over 100 participants from across our markets participate. Some minor build issues were identified, but a great benefit of the user acceptance testing was for participants to come back to the offices having had their hands on the new build and share with the offices that the change was less scary than they thought it might be and definitely reduced anxiety before go live. We did offer live webinars with Q&A with some of the builders like myself. 13 webinars were offered with over 1,200 attendees. Training was mandatory and supported by our operational leaders, and we did make a recorded webinar available for folks who were not able to attend the live webinars, but we only posted that after the live webinars were completed, really trying to encourage folks to attend the live webinars so that they could benefit from the Q&A sessions as a part of that experience. We did elect to do a pilot, again, with the number of practices and the number of end users who would be impacted by this change. It was important that in addition to the survey, the work groups, and the user acceptance testing, that our new build was live with real providers, real staff, real patients, and real environments before it went live across the rest of our practices. So we did pilot in an internal medicine and pediatrics department 2 weeks prior to the go live. Again, this was a great opportunity to identify minor issues, which we could correct before they would have impacted a lot more users. For our go live, we did have a command center with folks from the project ready to support any tickets that came in related to the project. We only had 21 tickets, which we thought was really low considering the number of impacted users. And we think that all of the implementation steps ahead of go live helped to keep that number low. Since a lot of the questions were educational in nature, I did meet with the service desk ahead of go live and provided them with the end user education and tip sheets so that hopefully they could resolve some of the issues that came in that were educational without having to transfer the ticket to our team, potentially delaying some resolution for our end users. So our go live was very successful. We did have a post-live process, and we had this planned before we went live, where we tracked enhancement requests throughout the implementation process. Any of the nice-to-haves that were not need-to-haves we put on an implementation post-live list for review by the work group that we had gathered prior to the project. This was crucial for keeping our project on time, given our tight timeline between build and go live. Those enhancements were prioritized, reviewed by our work group, and implemented in September, which was 4 months post our go live. This is also a helpful process because even with all of the feedback that we received from our end users, once they were live using the system, they had more input to give on the workflows and some of the reports that we offered in the sidebar. So some lesson learned on our implementation was our end user engagement was crucial. Again, with the number of practices we were impacting and the number of users that we were impacting, involving our clinical staff from the beginning through the survey, the work group sessions, and the end user training and the end user testing was crucial to the success of this project. One thing that we would do differently next time is share the communication about the project more broadly and more often with the providers who work in these practices. From the beginning, it was always thought to be a project for clinical staff and that it wouldn't impact providers, but as we all know with team-based care, what the clinical staff does during rooming patients does impact the providers. And so many providers didn't necessarily engage in the communication and the changes that were going to be happening within the practice. And so we will highlight that more in the future so that there is awareness throughout all phases of the visit and the staff involved in the visit. The plan enhancement phase was crucial to keeping our project on track and going live on time and allowing a feedback loop for enhancements post-live. We did administer a post-live survey following go live where we did collect some additional enhancement requests and combine those with ones that came up throughout the design and build and validation process. And that became the final list that was reviewed by the work group ahead of the September post-live enhancement phase. And again, mandatory training, while not always easy to operationalize, was crucial to minimizing any sort of negative impact that this project might have during go live, considering how different the workflows were for our end users. So now I'd like to circle back to the goals and opportunities that I presented at the beginning of the slides and see how we did with some data and some results. So our first goal was to streamline and standardize our primary care rooming workflow, which we did through the consolidation of our configuration records and implementing a single solution across all of our 300+ primary care offices. The next goal was to easily identify tasks needing completion. So let me jump into some details on here. So one of our visit checklist items was whether or not a fall risk screening was due during that particular visit. And as you can see, our success rate for that screening was improving up ahead of the project, but continued to grow at an increasing rate between April and May and throughout the remainder of the year. And again, I think the crucial part here was staff not having to go and look in the chart to see when it was completed last or remembering at which age the fall risk was due, but by having the visit checklist prominently display on the screen, staff knew when the fall risk screening was due or not due for that patient. Our completion of screening for depression also improved significantly, 28% between May of 2017 and April of 2018. Again, without requiring the staff to look through the chart to identify when the screening was previously completed or having to remember for which patients this was applicable, the visit checklist item made it clear when the depression screening was due. The visit checklist item reminding staff to mark the medication list as reviewed also jumped significantly, as you see, between April and May of 2017 when this project went live, and consistently stayed at that higher rate throughout the remainder of the year and into 2018. Similarly, the visit checklist item reminding staff to review and mark the allergies as reviewed also improved significantly between April and May of 2017 when the project went live, and also maintained that high number consistently throughout the remainder of 2017 and into 2018. Seeing these significant improvements between April and May really showed our team that staff is looking at the visit checklist and it is positively influencing behavior by having the visit checklist so prominently on the screen. As I mentioned, another visit checklist item we had was to sign the patient up for MyChart, the patient portal. The visit checklist item shows whether or not the patient does or does not have access to the patient portal, and prior to this project, not many staff actually signed the patients up during the visit. Rather, they would provide a code that the patient could sign up for the patient portal following the visit. This visit checklist item would only be satisfied by signing the patient up during the visit. So for our staff that really liked seeing that green check mark and seeing everything was completed, really was encouraged to change behavior and not only provide the patient with a code to sign up after the visit, but instead to get them signed up right there during the visit. As an organization, we've been working on increasing our patient portal activation rate. This project was only one small piece of that overall initiative, but we did notice between April and May of 2017, our activation rate went up by 0.8%, which was the highest monthly improvement that we had seen to date at that time. And I'm happy to report that by the end of July of this year, we're already up to 48.9% across primary care. This is really important for us that patients are engaged in their care through their patient portal, but also can take advantage of all the conveniences the patient portal has to offer, including scheduling visits directly with their providers. And finally, the visit checklist item that reminds staff to document the patient's smoking status and to document if smoking cessation counseling was given also had a significant increase due to this project. Now, when I first looked at the data, I was surprised and a little bit confused to see that between April and May, where all the other jumps were noticed ahead of the May go live, there was not a significant or noticeable change. But when I reviewed the list of post-live enhancements that we put in September, I noticed that we did update the visit checklist item for smoking status documentation and smoking cessation counseling documentation. And by simply updating the rule behind the scenes to make that visit checklist item more successful, you can see how that directly impacted this quality measure between August of 2017 and September of 2017 when that bucket of enhancements went live. This further proved to our project team how flexible the visit checklist was, how we could continue to modify it over time, and how, again, it had direct impact on the behavior and steps that our clinical staff, rooming patients, had in the rooming process. Our next goal or opportunity was to increase our care gap closure and how our rooming staff could impact this for our patients. So let's take a look at some of the data following go live for some of our care gap closure rates. Before jumping into that data, it was important to us that we had end user buy-in on the rooming smart set for our clinical staff. So in the post-live survey, we asked if staff members were aware of the importance of this health maintenance rooming smart set on the overall care gap closure and thus health of our patients. And as you can see, the overwhelming answer was yes. And so not only can we put a tool out there, but it's important to have buy-in from our end users, and we determined from our post-live survey that our end users did understand how important this was within their workflows. So we put it out there, we have buy-in, is it actually being used? So this slide shows the utilization rate of the health maintenance rooming smart set over time. So as you can see, in April 2017, before our go live, we did have a few uses during our pilot, and then every month since then we've had a great rate of usage for this order set. It's actually our most highly utilized order set in our system. And all told, by the end of July of this year, we had 39,910 unique uses of this order set in our system. So some of the care gap orders, as I mentioned, included in that smart set, which we have 14 currently, we wanted to see if any of these care gap closure rates were improving following the implementation of this smart set. Now, there's a lot that goes into whether or not care gaps are being closed. Pending the order is one small step in the overall process. The orders still need to be signed and carried out by our providers, or pardon me, by our patients, and we do feel that queuing up the orders for the providers have made at least some small impact on getting those care gaps closed. This is one example for the diabetic foot exam, a significant increase between April of 2018 and May of 2018, and continues to rise. Similarly, with our breast cancer screening, also has risen over time since the implementation of the rooming smart set. Colorectal cancer screening also has increased steadily since the project went live. Pneumonia vaccination also showed improvement since go live. For some of the quality measures, there's natural fluctuation throughout the year. And so for this particular slide, I wanted to show 12 months from May 2016 to April 2017 before the project went live, and then May 2017 to April 2018 after the project went live. As you can see, there's some variations that are similar from 2016 to 2017, or from 2017 to 2018 in the same month of the year. But overall, the numbers increased the year following the project go live. And for quality measures like this, while the clinical staff can't impact a particular value of a lab test, quality measures that are looking that a lab test was completed and the value was at a certain level, the rooming staff can help impact whether or not that test gets done and completed. For controlling high blood pressure, so within the visit checklist, we advise staff to do a blood pressure recheck if the result is abnormal. And how this helps this quality measure is that if the second reading is no longer abnormal, with proper technique and doing a recheck, we can avoid having some false positive patient values as part of the denominator for this quality measure. And finally, were we able to complete all of our goals with data capture, quality improvements, and care gap closure without adding more time to the rooming workflow? Well, unfortunately, we don't have hard data on the exact minutes out of Epic for rooming, but we do have some anecdotal feedback from our MAs through our post-live survey. So the patient information report on the sidebar that we developed specifically with our clinical staff feedback, we asked staff to indicate which sections of the report they viewed while rooming a patient. And as you can see, a lot of that report is being viewed. So for each of these items here, we're saving clicks and time that the staff no longer has to look other places in the chart to find this information, possibly saving several minutes, if not more, from each patient visit. So this first testimonial, while not extraordinary, as a person who implements change in a system where people don't like change necessarily, sometimes feedback such as this is good enough. The fact that staff didn't find this change as bad as they had feared, in my book, was a success. But we also have a slightly better quote as well. One MA shared that she had been working in Epic for 17 years, and this by far was the best upgrade for MA workflow than she had ever seen. So we do believe that we were able to implement this change and improve data capture, quality, and care gap closure, while also improving the overall workflow and finding efficiencies within the existing workflows so that we could support this new initiative without increasing time spent rooming, and hopefully overall still decreasing time spent rooming while improving the overall success of rooming. So the next steps for our team, we will continue to modify the rooming workflow and build, specifically the visit checklist items and the health maintenance rooming smart set to improve quality and care gap closure. We are also evaluating the rooming smart set usage throughout all of our markets to see if there's any opportunity for increased adoption or re-education around that order set. We are also considering if there are opportunities to incentivize rooming staff based on the successful rooming standards that have been set out regarding the visit checklist and health maintenance rooming smart set. And we are excited to take this workflow and extend it beyond primary care, which we are planning to do later this year in the following specialties. We are starting back at the beginning of our implementation cycle with the end user engagement survey, which is currently live, and we are currently collecting feedback and volunteers for work group sessions for clinical staff who room patients in our specialty offices. There were a lot of folks involved in this project who were crucial in making this project a success. A few I've included on this slide for your review. And with that, I'd like to thank you for listening to our outpatient case study and hope that there are some steps that I've shared with you today that you can take forth for your organization to improve quality and patient care gap closures.
Well, thank you, Carrie, and thank you for that wonderful presentation and for joining us on this Davies webinar. Today, I want to remind folks where to go find more Davies use case webinars like this one, and that information can be found at the HIMSS Davies Award website at hims.org/Davies. So that you can find more Davies use case webinars and information on how to apply Davies at this website. Again, thank you so much for joining us.